Hi everyone, I am Jennifer Purwin. I am a doctor of physical therapy and a pelvic floor specialist, and I'm with Fem First Health here in Manhattan. So today I'm going to talk about the journey to getting treated for tailbone pain. So tailbone pain it can be pretty terrible. We kind of take for granted the ability to sit for any amount of time or stand up without pain, so that if you do end up with a tailbone or coccyx issue, that can be extremely disruptive. And so we see a lot of people who are very, very eager to find a solution. I will say that treating tailbones is very tricky. Oftentimes it requires more than one kind of provider, but not always. So I'll talk a bit about where PT comes in and what we're looking for, and also some other kinds of providers that might be part of your journey if this is something that you're going through. So when someone comes in for tailbone pain, first we'll talk about when the pain actually shows up. For many people, it's when they're sitting down. Sometimes it's immediately upon sitting. Sometimes it takes a little while and builds up. For some people, you stand up and the pain goes away. Other people, you stand up and you have sudden sharpness. Or you stand up and you have something that's lingering. So as you're walking along, it takes a while to kind of shake that off. Or you might even start to feel something radiating into the thigh or the foot, or maybe in any place sort of along the leg or the pelvis where your body's kind of compensating and clenching and just trying to sort of separate you from that pain. So we have conversations about how it got started. For some people, they know there was an accident and then they had tailbone pain after that. Or there was an accident and then several months or a few years later, they notice it's starting to build up. So it's not necessarily something that suddenly happened and then you're getting symptoms. For many people, it's what we call insidious onset, where it just slowly builds up and we're not exactly sure where it came from. When we're looking into that, oftentimes we're looking at posture. For example, if somebody maybe had an ankle injury at one point, so even kind of their gait versus their posture, where they're walking and it might change their gait slightly, or if someone took up doing maybe marathons when they were just doing 10Ks and they had some kind of change in the way their foot hit the ground. So there was an unevenness and that kind of tension sort of travels up the leg and is finding a place to go. As for actually seated posture, sometimes there can be a link to if you're sort of always sort of tucking under, if there's sort of a natural clenching that you're doing. And I'm not saying that any one of these things is going to give you tailbone pain, but these are little things that we look for that we might also try to adjust when we're figuring out where that pain came from, how to treat it, and how to make sure it doesn't come back with normal everyday movement. So once we've talked about kind of the background and gotten maybe an idea of the person's sort of physical history, injuries, how they stand, sit, walk, activity level, type of activities that they're doing each day, then we'll look at the physical evaluation. So for pelvic floor physical therapy, there are three approaches. So one, I start with external, where the person is lying usually on their stomach, depending on what they're able to do. Sometimes we have to do this in side lying. And I'm looking basically from the outside and palpating, meaning trying to feel that tissue to get an idea of where the tailbone is and what actually provokes that sensation of pain. So we're looking at how your hips are aligned, then we're looking at the sacrococcygeal joint. So this is the joint between the coccyx, the tailbone, and the sacrum, which is the triangle bone in the pelvis. Sometimes people will say, that's it, like I sit down, that's where I feel it. Okay. And so if I'm palpating along the tailbone and I create pressure, maybe on one side of that or the other, they'll say that side or that side, and that might be what we're focusing on. Other times I might be working along the tailbone and in the gluteal cleft, so for lack of a better term, the butt crack is the gluteal cleft. And you're kind of working out on that tissue, and sometimes it's like a tugging sensation that might be lower in the tailbone, or I'm pushing lower and they feel it at the sacrococcygeal joint. Other times it's right at the inferior or kind of tip of the tailbone. So the reason this might be is because tailbones are different for every person. Technically, it's a fused bone of several bones that kind of used to be. So basically, you can have more or less mobility at different points of the tailbone. So you might have like the bigger part, which is the body, or maybe there's just like a wiggly part kind of right at the tip. And sometimes that little wiggly bit starts to get yanked around. Now the pelvic floor comes in is that the pelvic floor muscles are attached to the tailbone from the inside. Or rather, they're attached to connective tissue that then attaches to the tailbone. So when you're contracting your pelvic floor muscles, that line of pull is going to involve the tailbone. Other muscles that are involved are another set of internal muscles, and then also gluteus maximus. So you would know this as the bigger buttocks muscles in the back, the ones that help you stand up and sit down, which is why some people, when they're standing up from a chair, they'll get that sudden pain because glute max squeezes and it yanks at that tailbone, and that's where that's where they have that moment. So I'm getting an idea, if I can, externally, what the mobility is too. Sometimes when somebody is sitting down, it's because there's so much stiffness in these joints that it can't naturally move a little bit to get out of the way. Really, when you're sitting, the tailbone is only supposed to take about 10% of your weight. Your sit bones are supposed to take the 90%. So again, if there's some difference in posture, or if the tailbone is stuck in one place, either kind of pulled out and extended, or flexed and pulled in, you just kind of might not be able to avoid it, and you're coming down too hard on that little bone that is not supposed to take that kind of weight. So we can find some of these things out from the outside. There are cases where you're not necessarily going to get as much information as you need, or there's a lot of sensitivity externally. And I usually try to check in these all three places anyway, because it really gives us this 3D view of what's going on and what we can do. So if we're now moving into internal, there are two approaches. So for female-bodied people, you can approach vaginally, and then there's the rectal approach. If we're able to approach vaginally, I do that first, because these muscles in the pelvic floor, they are the muscles that make up the lining of the vaginal canal, and they wrap around the anus and attach to the tailbone. So all of this muscle tissue is relevant. I'm just at different parts of it, kind of like I'm pressing on my arm, I'm also pressing on my arm, like that. So when I'm working vaginally, I think we have another video on like what a pelvic floor exam looks like, so maybe I won't totally go into that, but I'm using one gloved finger, lubricant, and ideally I'm trying to feel the muscular walls of the vaginal canal to get an idea of how they're behaving. Sometimes when I'm gently working on those walls, the person will report, oh, I feel that in my tailbone, or oh, I feel that in my sit bones, which indicates actually there's a muscle that slings from the tailbone to kind of around the sit bones. And we can get information there, and sometimes we're able to actually diffuse some of that tension working vaginally. So you're already trying to get rid of some of that before we even move to the rectal exam, which is usually if something is going to be challenging, it tends to be that one. So that's what we're trying to find out vaginally, and also trying to maybe even treat a little bit before we try something that's a lot more direct. Then for the rectal examination, same kind of thing, one gloved finger, lubricant. And we're trying to move past the sphincters of the anus and then eventually try to get to the tailbone. So sometimes the musculature in the anus, or around the anus and in the rectum, is so tight I can't even get to the tailbone. So we have to do that work first and get all of that to relax down. Eventually, that is the goal, for me to be able to actually get hands-on on that tailbone. Sometimes it'll be super flexed or immobile in a certain way, or too mobile in other ways. So I need to be able to feel that if I'm going to have an effect on it. Let's say, for example, like the little tip is super mobile and I can feel tense pelvic floor muscles coming off of that. So I'm sliding over and I'm treating that muscle. Let's say maybe the tailbone is super flexed and curved in. So then I'm trying to work my way to get to a place where the muscles are basically at ease enough to let me do this where I can get to the body of the tailbone, or I can get to the segment that's flexed and gently start to mobilize this. At the same time, I might be in the gluteal cleft externally, also trying to just access that muscle from the outside and make that a lot easier. So if someone is super flexed, that's what coccyx mobilization or manipulation is. I'm not doing some jerky, sudden movement or anything like that. There's really a lot of work that happens before you're approaching that, and you want to find out if this is something that is actually appropriate for the reason that someone has that tailbone pain. So let's say we've done all of that. We're pulling back a little bit. We're also looking at, well, if it was something about posture, about gait, about maybe overactive musculature in one side of the glutes or the other, something like that, we have to work on that too. So there often is an orthopedic component. For me, I'm oftentimes strengthening the muscles on the side of the buttocks, so glute med, glute min, and trying to take some pressure off of glute max, maybe working directly on those muscles just to get a bit of a release, releasing muscles around the hamstrings or the inner thighs, basically anything in that area, or even maybe not in that area, that's having an effect on the muscles most closely related to the tailbone and tailbone positioning. Okay, so that's PT. And for a lot of people, this is not necessarily the first step in their journey. A lot of people will see a healthcare provider who is able to treat with injections or basically a pain type specialist. And I've worked with some really good people who know what they're doing. I will say, again, treating tailbones is difficult. You can't isolate them. If you break your arm, you can put it in a cast and immobilize it. You can't do that with the tailbone. And I can't tell someone not to sit. You can use a wedge cushion and offload it, but that's it. There's just no way. There's so much musculature around that little bone. So it's difficult for any provider to treat, which is why sometimes it might take multiple providers in order to get a full resolution of that pain. And so when working with someone like a physiatrist or someone who specifically said, well, I'm an orthopedist who works with tailbone pain, or they don't necessarily even have to have that title. If someone knows that they work with tailbone pain, they say they work with tailbone pain, then they will have a more sophisticated idea of where you might need an injection and what kind of injectable to use. And so that is a thought process. I am not that kind of provider, so I can't get too deeply into that. But I can tell you that sometimes people will inject a little further down because maybe that's where we need to be. Maybe they have to get up above the tailbone because that is where the nerve response is. That's sort of the crux of it, and we need to be there. That kind of decision making is also not very easy, which is why sometimes I will see people after they have done an injection series, or maybe done an injection series that wasn't quite right, and they either it was better for a little bit, or they felt a difference for a little bit of time, or maybe there was no difference. So it doesn't mean that injections are necessarily bad. They're not necessarily for everybody. Sometimes you can just do PT, and that's the whole thing. Sometimes PT is actually not the answer. An example of that would be kind of a bony growth or a bursa. I can't shave that down for you. That's also, don't look for that. No one does that. And so, but in that case, you would be looking more at an injection series. Maybe PT would be an element as far as the way you sit or walk. And then I'll talk very briefly about coccyx removal surgery. Almost no chance this is going to be something that you encountered or were offered. At this point, I think so I'll say I've seen a couple. There were some really severe, complex cases, mostly that there was a shattered sacrum and the tailbone was kind of involved with that. That's a different case. But coccyx surgeries are not very popular because they weren't especially efficacious considering what you had to do with removing the coccyx. Also, when you take the coccyx, the tailbone out, you have to reattach all of those muscles to something. So I have worked with people where they had the removal surgery, maybe they had a difference for a while, but then they would sit down, and even if they were offloaded, even if they're not even necessarily leaning back into that area, they would start getting that nerve pain because there was scar tissue and we had to work on that. So it's very complex, extremely unlikely that you're going to end up in a situation where you're looking at a removal. Most people aren't going to want that anyway. I think the last kind of things I read about it is there's maybe a 25% rate of getting the outcome you want. But on the other hand, there are some extreme or unique cases that do require that. So I just want to put a little bit there. But that, I think, in general covers most of what you might see in that journey. I'm glad that we were able to do this video because I do see people after they've seen a few people and they're pretty desperate, and it's not, for any reason, it doesn't feel great to get kind of passed between providers and not get relief when you're in pain when you're doing something like sitting. And that's not necessarily, like some systemic fault. It's hard to treat tailbones, but if you have an idea of all of these things, you hopefully will have a better idea of what to look for when you're seeking treatment. So if you want to chat with us more about that, again, my name is Jennifer. I am with Fem First Health. We are on the Upper West Side and in Bryant Park. And please feel free to reach out to us via the website. You can schedule a consult if you want to do a free consult with one of us or with me, and you can also just call and get yourself on the schedule so we can chat about symptoms you're having. So I think that's all.